Hey everyone, welcome to today's CE. We're going to begin here in just a moment. While you're waiting around, before we begin, did want to make sure that everyone knew that we do have a podcast called Infarm's EBM Podcast that you can find on Spotify and iTunes. That's available and it typically coincides with our CE topic for the month. So if you have a moment, please feel free to check that out. Hello everyone and welcome to this Infarmed CE Masterclass, where we aim to eliminate redundancy in drug information to drive evidence-based care. I'm Scott Perkins and I'll be the presenter for today's CE. If you've been with us before, you likely already know the rundown regarding how this works, but for those of you who are new to our CE, well, first, welcome. Infarmed has a database of over 10,000 different drug information requests that they've received over the past years from healthcare providers across the United States. Now, what we've found is that 40% of the time that we receive a new request, it's technically one that we've already answered previously. So as a result, we wanted to develop some continuing education programs based on some of the popular drug information requests so that we can be proactive and to answer requests that you might have before you even send those requests our way. Now, that being said, if you have a specific topic that you'd like for us to develop a CE around, please do not hesitate to contact Janvi at janhavi@infarmed.com. Thanks, Janvi, for all you do. Today's CE was developed by three pharmacists, Janvi Panyarthi. She developed the material for today's programming. She's the Director of Brand Management at Infarmed. Yutong Yang is a drug information specialist at Infarmed and acts as the Infarmed drug information liaison for our continuing education. And like I said, I'm Scott Perkins, and I'm a clinical associate professor at Campbell University's College of Pharmacy and Health Sciences, and a co-director of our Drug Information Center. At my institution, I've also been an academic partner with Infarmed for the past several years. Of course, it's important to note that the three of us have no relevant financial disclosures to make with regard to the CE program. Okay, so now that we've covered all of that, let's get into today's CE. The title for today's continuing education program is What is the Safety and Efficacy of lecanemab in the Treatment of Alzheimer's? Today's learning objectives are to recall clinical characteristics of lecanemab, to describe how lecanemab works in Alzheimer's, to evaluate the applicable medical literature regarding lecanemab, to recognize the positives and negatives of using lecanemab in clinical practice, and to compare and contrast using lecanemab versus aducanumab in clinical practice. Lecanemab is an anti-amyloid beta monoclonal antibody that received accelerated approval from the FDA in January of 2023, so pretty recently. It slows the pace of cognitive decline and prevents aggregation of amyloid beta plaque in patients with early Alzheimer's disease, the most common type of dementia. Specifically, this indication is solely for those patients with mild cognitive impairment or mild dementia. It's available in a solution for IV administration, with sodium chloride being the preferred diluent. Lecanemab is administered in a clinic every 2 weeks at a dose of 10 milligrams per kilogram of adjusted body weight. As an anti-amyloid monoclonal antibody, lecanemab targets aggregated soluble and insoluble forms of amyloid beta therapy, reducing the plaques that arise as a result. Since lecanemab does not undergo renal elimination or metabolism by hepatic enzymes, there are no dose adjustments recommended for patients with kidney or liver impairment. Geriatric and pediatric populations also have limited data to support dose adjustments. The United States Food and Drug Administration has supported a couple of different warnings in the product labeling for this medication, including amyloid-related imaging abnormalities. The first of these imaging abnormalities is related to edema. This includes brain edema and sulcal infusions. These generally occur within the first 7 doses of therapy. In addition to this, there's also abnormalities related to hemosiderin disposition, which might occur and lead to microhemorrhage and superficial siderosis. These abnormalities are typically more common in individuals with apoepsilon 4 and generally present as a headache, altered mental status, visual changes, dizziness, nausea, gait difficulty, and possibly focal neurological deficits as well. As with many monoclonal antibodies that are given by injection, infusion reactions might occur. These reactions often present as fever, flu-like symptoms, nausea, vomiting, maybe some hemodynamic instability, and lowered oxygen saturation as well. Speaking of infusion-related reactions, they are indeed the most common adverse events associated with lecanemab and occur in about 20% of patients, while head ARIA edema and ARIA hemosiderin occur in 14, 10, and 6% of patients respectively. Lecanemab vials are single-use. Unused vials should be refrigerated in the original carton to protect them from light exposure. To prepare for administration, you should first calculate the patient's specific dose. Solution in the vial should be clear to opalescent and colorless to pale yellow. Withdraw the required volume from the vial and add to a 250 milliliter normal saline infusion bag. Gently invert to mix, don't shake. Prior to infusion, allow the diluted solution to warm to room temperature if it was refrigerated. The prices for the 2 milliliter and 5 milliliter vials are both about $153, and most patients will only need 1 or 2 vials for a single dose. Now, let's get into some of the literature surrounding lecanemab. There's a fair amount to cover, but I think for this medication it's particularly important to understand some of the strengths and limitations with regard to its clinical applicability. The first trial that we'll cover is a phase 2b proof of concept trial, and this trial evaluated the use of lecanemab in patients with early Alzheimer's disease. This trial was multi-center, double-blind, placebo-controlled, and used response-adaptive randomization and included 856 patients. Authors sought to assess monthly and biweekly doses of lecanemab at 2.5, 5, and 10 milligrams per kilogram for patients with early Alzheimer's disease, mild cognitive impairments due to Alzheimer's disease, and mild Alzheimer's disease. Patients with mild cognitive impairment due to Alzheimer's disease who were confirmed to be amyloid positive and had an MMSE of greater than or equal to 22 were included. Patients could be either naive or on stable Alzheimer's disease therapy for 12 weeks. Patients were excluded for several reasons, including neurological conditions that contributed to their condition outside of Alzheimer's disease, a history of TIA, stroke, or seizure within 12 months of screening, clinically significant lesions on MRI that may indicate conditions other than Alzheimer's disease. Patients were randomized to either placebo or 5 lecanemab arms. To maintain the blinding, all subjects received biweekly infusions of either placebo or lecanemab. A Bayesian design was implemented to identify the effective dose of 90%, the ED90, defined as the simplest dose, or the earliest in the order of convenience of 5 milligrams per kilogram monthly, 10 milligrams per kilogram monthly, 2.5 milligrams per kilogram biweekly, 5 biweekly, and then 10 milligrams per kilogram biweekly. That achieves greater than 90% of the maximum treatment effect, and to allocate more subjects to the most likely ED90 dose at each interim analysis, while putting fewer patients on less effective doses. If the trial was not stopped early for futility or success, then the trial's success would be evaluated at 18 months. If there was an 80% probability that the most likely ED90 was better than placebo by the clinically significant difference of greater than or equal to 25%, or during any time during the analysis, the trial would be considered a success. Notably, Emerging data from the study just prior to the 350 subject interim analysis indicated that patients who were positive for homozygous apolipoprotein epsilon 4, who were on the highest dose of lecanemab, 10 milligrams per kilogram biweekly, had the highest risk for developing symptomatic amyloid-related imaging abnormalities, focusing on edema and effusion, or ARIA-E. A protocol amendment was made in that apo epsilon 4 carriers, homozygous or heterozygous, were no longer administered the 10 milligram per kilogram biweekly dose of lecanemab going forward. And this approach was adopted for all subsequent randomizations. At the same time, a request was made to discontinue the study drug in all apo epsilon 4 carriers who were randomized to the 10 milligram per kilogram biweekly dose and were on the study drug for less than 6 months. The primary outcome for this study was the change from baseline at 12 months on Alzheimer's disease composite score, or aducanumab. Secondary outcomes included changes from baseline at 18 months in the brain amyloid by PET scan. They also looked at clinical dementia rating sum of boxes, or CDR-SB, Alzheimer's disease assessment scale, and cognitive subscale, or ADAS COG-14. And these are clinical markers typically looking at diagnosis of Alzheimer's disease. Baseline characteristics were reasonably well balanced across the doses for each category, with the exception of apoepsilon 4 status. The imbalance in apoepsilon 4 status on the 10 milligram per kilogram monthly group and the 10 milligram per kilogram biweekly group is directly related to the change in study design brought about by the health authority interactions. It's important to note that about 65% of patients had mild cognitive impairment, and the mean mini mental state exam was between 25 to 26. This is important since we commonly think of an MMSE of around 24 being associated with dementia. In terms of results, the 10 milligram per kilogram biweekly dose had a 64% probability of being better than the placebo, with 25% less decline on the ADCOM. Now, this does miss the pre-specified 80% probability threshold for the primary outcome. The Bayesian analysis at 18 months identified a 76% probability of being better than placebo by 25% on the ADCOMs. Improvements were noted on the patient's PET scans as well, with the largest being with the 10 milligram per kilogram biweekly dose. Common adverse effects included infusion-related reactions, which were seen at a much higher rate in patients taking 10 milligrams per kilogram, either monthly or biweekly. Rates of infusion-related reactions for 2.5 milligrams per kilogram doses ranged from 3.3 to 5.8%. 5 milligrams per kilogram doses were associated with infusion-related reactions at 7.8 to 12%. There was a stark increase that was seen with the 10 milligram per kilogram doses, as 20 to 23% of patients had infusion-related reactions on this dose. Similarly, amyloid-related imaging abnormalities with edema, ARIA-E, were noted to be seen in much higher rates in the 10 milligram per kilogram group at about 10% of patients. The authors concluded that the 10 milligram per kilogram biweekly dose, despite being limited in size and the apoepsilon 4 balance, showed nominally significant differences versus placebo on the ADCOMs and ADS COG-14 at 18 months of treatment. The 10 milligram per kilogram monthly group demonstrated intermediate effects relative to placebo across assessments, but these differences were not nominally significant. None of the other groups differed from placebo, most likely due to the relatively small sample size allocated to the suboptimal doses by the Bayesian adaptive randomization algorithm. It's important to note at least one major weakness of this study, and that is the fact that a large number of patients were removed early. These were individuals who were apoepsilon 4 positive, taking 10 milligrams per kilogram. As a result, the study is not as easily extrapolated to a real-life population. Keep in mind that the patients with apoepsilon-4 taking the highest dose of lecanemab were associated with higher incidence of amyloid-related imaging abnormalities or ARIA, edema, and infusion. So we don't have any definitive data on the risk for this population, but it may likely be higher than the 10% noted in this study. Following this study, there was an open-label extension utilizing the same patients. This study was authored by McDade and colleagues. 180 patients were included in this extension study, and all were given lecanemab 10 milligrams per kilogram biweekly. Of these patients, approximately 1/4 had previously received placebo. Another quarter previously received 10 milligrams per kilogram biweekly, and just over half of the patients received doses other than 10 milligrams per kilogram biweekly. Patients in this extension study could have completed the previous study or discontinued the study in the initial trial for various reasons, including ARIA, taking previously prohibited medications, and those who were apoepsilon-4 positive and received 10 milligrams per kilogram biweekly. Similar exclusion criteria were also noted in this study compared to the previous study. Researchers sought to assess the long-term safety and tolerability of lecanemab by giving patients lecanemab 10 milligrams per kilogram biweekly for 24 months. On average, the gap period, or kind of washout phase, was 24 months, but this ranged from 9 months to nearly 5 years in some patients. Similar outcome measures were utilized in this study, including several clinical markers of Alzheimer's severity, such as ADCOMS and CDR-SB. Baseline characteristics were notably different in some expected categories. Before we take a look at that, please note that the group on the far right is representative of all patients included in this extension study and not patients on doses of lecanemab other than 10 milligrams per kilogram. So that is representative of the entire population in this study. The amyloid centiloids, which are essentially amyloid beta plaques, do differ quite significantly in the groups who were previously on placebo compared to those who were on lecanemab. The concentration of the centiloids were about 9 times higher in individuals on placebo compared to those on 10 milligrams biweekly. In addition, the placebo group had 10 times the number of apoepsilon-4 carriers compared to the 10 milligrams per kilogram biweekly lecanemab group. Importantly, clinical markers of disease state improvement like ADCOMS and their MMSE were similar between groups. Results evaluating amyloid beta plaque reduction illustrate that there was a significant reduction throughout the first study in various biomarkers associated with dementia, including beta amyloid plaques and tau proteins. This reduction was noted in the first 18 months of therapy in the core trial that we discussed earlier. These values began to approach one another in the extension study, in which all patients were taking the study drug. It's important to note that these biomarkers are correlated with Alzheimer's dementia and don't yet have data to support them as causative markers for disease state improvement. That becomes more important when we look at some of the clinical rating scales. So let's go ahead and look at those now. Now, there are several markers we often use to diagnose and determine the severity of patients' Alzheimer's dementia. The CDR-SB is the clinical dementia rating scale, and scores range from 0 to 18, with mild cognitive impairment being noted around 0.5 and 4. The ADAS-COG stands for the Alzheimer's Disease Assessment Scale, cognitive subscale, and ranges from 0 to 90, with mild impairment noted with scores between 8 and 15. The Mini Mental State Examination, or MMSE, ranges from 0 to 30, with score ranges from 24 to usually 27, indicate mild cognitive impairment. And the ADCOM score is the Alzheimer's Disease Composite Score and is actually derived from a weighted calculation involving all of the scores that we just mentioned. The score can range from 0 to 1.97, with ratings between 0.11 and 0.33, indicating mild cognitive impairment. Let's look at the results of this phase 2 trial with that in mind. First, the data from the clinical dementia rating scale, which ranges again from 0 to 18. The average change from baseline is represented on the graph alongside the standard error of the mean. Keep in mind that the standard error of the mean is typically not preferred when assessing data, as it's often much smaller than the standard deviation. Notice that the mean change from the groups is not drastically different. And whether on placebo or not, the control group does not differ more than 1 over the intervention group. In addition, we see that the standard error of both groups do end up overlapping in the extension phase of this study, and suggesting that results are likely not statistically significant. If we look at the ADAS COG group, we'll notice that the groups differed by approximately 2 to 3 points, but both groups continued to worsen throughout the rest of the study. This is also noted with the ADCOM scores as well, that composite outcome. In fact, we actually see a standard error of the mean overlap here again in the extension study. Now, if you recall, the baseline composite score from the previous study was approximately 0.4 in each group. So based on this information, it would appear that patients in both the placebo group and the treatment group would be categorized as moderate cognitive impairment, as their composite score increased by about 2.9 or more. So they would fall outside of that 3.3 range, most likely. The authors of this extension study identified that lecanemab treatment resulted in significant reduction in amyloid plaques and a slowing of clinical decline. Data indicate that rapid and pronounced amyloid reduction correlates with clinical benefits and potential disease-modifying effects, as well as the potential to use plasma biomarkers to monitor for lecanemab treatment effects. But there are some important factors to consider when evaluating this study. Results during the extension phase are primarily presented in graphs without pre-specified numerical values. The gap period in the extension phase helps to provide valuable insight into both the effects of lecanemab on Alzheimer's disease after its discontinuation and its continued efficacy upon restarting that dose. However, this study could have benefited from the inclusion of a safety analysis comparing the rates of adverse events upon reinitiation of lecanemab following an extended break to those rates that were observed in really the initial core period. So we have a missed opportunity there with this study. Let's take a look at our phase 3 trial. This was a multi-center, double-blind, placebo-controlled trial. In this study, authors sought to determine the safety and efficacy of lecanemab in patients with early Alzheimer's disease, so a similar patient population to our other studies. The 1,795 patients in this study were divided into a treatment group in which 898 patients took lecanemab, 10 milligrams per kilogram biweekly, and a control group in which 897 patients took a placebo. Both inclusion as well as exclusion criteria were similar to the other studies we discussed earlier. The primary outcome of the study was the change in baseline at 18 months in the CDR-SB score, which we already discussed. Again, this is an 18-point scale in which normal would be considered 0, and 0.5 to 6 is representing early Alzheimer's disease in this case. Secondary outcomes include both clinical scales as well as biomarkers for amyloid beta plaques. Baseline characteristics were similar between both groups. More patients had mild cognitive impairment as opposed to dementia due to Alzheimer's disease. In addition, the majority of patients were also apoepsilon carriers. According to cognitive scores, patients included generally had mild impairments, which is in line with the study's baseline characteristics. After a year and a half of therapy, 18 months, the change in CDR-SB was 0.45. Now, this was assessed to be significant with a p-value of less than 0.001. And remember, this is a scale from 0 to 18 in which the range from early Alzheimer's was 0 to 6. As expected, the change from beta amyloid plaques was significant in lecanemab group. Now, alongside the CDR score, authors identified a difference on the COG-14 score of 1.44. And again, this is a scale from 0 to 90. So we saw a change between the treatment group and the placebo group of 1.44 on that scale of 0 to 90. The ADCOM score, those scores were also significant with a difference of 0.05. And again, the score ranges from 0 to 1.97, with scores between 0.11 and 0.33 indicating mild cognitive impairment. Now, some meaningful adverse events were noted in this study, with 26.4% of patients taking lecanemab experiencing an infusion-related reaction, and more patients overall experiencing serious adverse events, including ARIA-E, atrial fibrillation, syncope, and angina. 7% of patients discontinued treatment due to adverse events. To put that into perspective, that's 1 in every 14 patients discontinued due to the adverse events that they were experiencing with this medication. Authors of the study found that lecanemab reduced markers of amyloid in early Alzheimer's disease and resulted in moderately less decline on measures of cognitive and function compared to placebo at 18 months, but was associated with more adverse events. Longer trials are warranted to determine the efficacy and safety of lecanemab in early Alzheimer's disease. There's also some other critical factors to consider. The primary outcome of this analysis, change in CDR-SB score, is not meant as an assessment of disease progression. CDR-SB is a tool for diagnosis. However, the consistent reduction in additional tools and questionnaires do allow for hypotheses that lecanemab may be able to slow disease progression. Additionally, the effect size noted here between the lecanemab group and the placebo group is pretty small. And thus, the clinical significance of those changes may be up for debate. The study includes a large sample of apoepsilon-4 genotype carriers, however, who make up about 69% of patients. Such individuals are removed from prior large trials due to the risk of ARIA-E. And so there's a benefit there for having those individuals within this study. It's also really important to note the dropout rate in this study. It was 17.2%, and that's a pretty high number, and certainly worthwhile to take note of. Let's end today's CE by taking a brief look at lecanemab and aducanumab, which came out a couple of years ago. Briefly, from a data perspective, aducanumab trials also utilize CDR-SB as their primary outcome. However, researchers did not find a statistically significant difference with lower doses of aducanumab, and only found differences in higher doses in the eMERGE study. Now, in this study, the effect size in the high-dose group was similar to lecanemab. For instance, lecanemab was favored over placebo by 0.45, which aducanumab was favored over placebo by 0.39 on the CRD scale. In terms of strengths and limitations of the available data on lecanemab, strengths include the fact that a blinded interim analysis was done to assess for early success or futility and to ensure patient safety during dose finding. A multi-center design was utilized for this trial, and researchers included a diverse set of race and ethnicity, which increases the study generalizability. Limitations of the data around lecanemab include the relatively short-term intervention for Alzheimer's disease of around 18 months, especially in that phase 3 trial. The use of ADCOMs and CDR-SB for the primary outcome, because this is mainly used for staging and diagnosis as opposed to Alzheimer's disease progression. Now, it's also important to note that occurrences of ARIA may have unblinded both participants as well as investigators. And finally, researchers used long-term monitoring of treatment effects using plasma biomarkers versus repeated PET scans to determine amyloid status. All in all, there is a lack of direct comparison data available between lecanemab and aducanumab, or other pharmacologic agents for Alzheimer's disease, meaning we just don't know which agent is truly more preferable. The decision on which agent we will use is likely going to come down to cost and safety. Lecanemab has been observed to reduce both amyloid beta plaque and Alzheimer's disease related symptom scores, with lower incidence of reported ARIA compared to aducanumab. Close MRI monitoring and dose interruption for ARIA, ARIA-E, and ARIA-H are required though. For the time being, available data have only evaluated the effect of both of these agents on patients with mild cognitive impairment or with mild dementia. So we can't guarantee the effect that these agents will have on patients with later stages of Alzheimer's disease. Going forward though, there are a couple of 4 and 5 year studies in the works, and these aim to evaluate that long-term efficacy of lecanemab. So it's going to be interesting to see what the data say about this medication and its efficacy long-term. For now, we'll jump back to live view and we'll do some review questions before we end things for today. Hey everyone, welcome back. Hope you enjoyed that short CE. I wanted to kind of finish off the rest of this CE program by doing a couple of knowledge checks. And to start that off with, I wanted to do this in an interactive fashion. So on your screen, you should see a couple of different steps that illustrate how you can participate in this interactive knowledge check and kind of recap. So you should be able to go to step 1 at the top of the screen. You should see view options. And in that options menu, you should be able to select annotate. Now, when you're in annotate mode, I want you to select that check mark. And you're going to use that check mark on the subsequent slides and to choose your choice. So let's go ahead and practice that. Just 1 minute. All right. So if you get a moment, I'll go ahead and try to practice that check mark in the grid on the right. Awesome. And I will do the same. All right. Fantastic. All right. It looks like we got a hang of that. So let's clear the screen and we will answer some preliminary questions. Here. All right. So go ahead and answer the question, how did you hear about today's CE presentation? Right. Fantastic. Looks like we've got a wide variety of avenues by which people have come to find the CE today. Next question is, please select what profession or area of practice best applies to you. Always get kind of fun with some of the random check marks you find on the screen. All right. So we got some folks in academia, some places in other, some not even on the map. So, all right. So our next question. Our next question is related to the CE from today. So the question is, which side effect may not commonly be seen with lecanemab? So is it cerebral edema? Is it microhemorrhage? Is it infusion-related reactions, or is it a decreased intracranial pressure? And I'll give you just a moment to answer. Looks like we have a lot of folks in D, which is decreased intracranial pressure. And that is correct. That is not likely to happen. In fact, we are more likely to see increased intracranial pressure with the utilization of this medication. All right, so our next question is, what clinical characteristics are associated with lecanemab? Which of these characteristics is false? So lecanemab is an anti-amyloid beta monoclonal antibody. Lecanemab is uses patient-based dosing and ideal body weight. When preparing lecanemab for administration, the solution vial should be clear and opalescent, colorless to pale yellow, or there are no renal or hepatic dosing adjustments required for lecanemab. So which of those is false? Like we've got some folks choosing B, and B is indeed the correct answer. We're going to be using adjusted body weight in this case. Right. What was considered a limitation of the phase 2 concept study? So there were multiple apoepsilon 4 positive individuals taking 10 milligrams per kilogram of lecanemab, and they were removed due to safety concerns or high adverse rates of adverse events. B, the study was not randomized nor powered, thus the statistical tests are not reliable, so they did not achieve power. The therapeutic dose of lecanemab was not included in the study groups. Baseline characteristics of subjects were not consistent in the different groups. Got a vote for A so far. And yeah, A is the correct answer. Looks like we got a lot of votes for A. Fantastic. Well, those individuals were removed well before the study began. So they were removed as soon as the study began as well. So our fourth question is, what was the primary outcome associated with the phase 3 study that we discussed earlier? It changes from baseline and amyloid, PET, SUVR, amyloid syntyloid, plasma, amyloid beta 42/40 ratio, plasma, tau 181, ADCOM, CDR-SB, or ADAS-COG14, change from baseline at 12 months on Alzheimer's disease composite scores, or ADCOMs, change from baseline to 18 months in score on the CDR-SB, or the composite outcome of ADCOMs and CDR-SB scores. In that phase 3 study, what were we looking at? It's like we've got a vote for C. Oh, we got a vote for B as well. Right. So the answer is indeed C, and this is similar to that phase 2 study that we saw too. They use that CDR-SB, which is, as we mentioned, sort of a limitation to a degree in the sense that while it is a clinical score, the CDR-SB is a little bit more focused on diagnosis and not necessarily on prognosis for Alzheimer's disease. And our last knowledge check. What limitations do we see with lecanemab that make it difficult to apply this treatment to clinical practice? A is there's a lack of direct comparison data available between lecanemab and aducanumab or other pharmaceutical agents. It may require close MRI monitoring and dose interruption for ARIA, both ARIA-E and H. The current data may not be generalizable to larger patient populations, or D, all of the above. Yeah. So the answer is all of the above. All of those are limitations with the use of lecanemab, unfortunately, at this time. So, but as we mentioned, there are some studies coming out in the future that are 4 and 5 year follow-up studies. So we do intend to get some more data about the use of this medication from a clinical standpoint and see what kind of long-term data we'll get with lecanemab kind of going forward. So those are all of the knowledge check questions that we have. If there are any questions, I am glad to attempt to answer those. Or point you in the right direction if the data is just not available yet. And here is the live CE code for today. Thank you all for joining, and we will see you in a month or so for another CE masterclass, and I will be helping out with that as well, I believe. So we'll see you then.